Thanks so much for having us here. It's a great pleasure for me to introduce my co-moderators and discussants, Dr. Almanfi from Texas, from the Heart Hospital, and Dr. Michael Stoner. He's a professor and chief of vascular surgery from University of Rochester. We're going to have a very didactic talk. We're going to start talking about beginning with the end in mind, good access, good closure. Thank Telfax for the symposium. These are my disclosures. The focus here will be about how to do vascular access, how to manage to do a good closure, and with the MANTA device. The MANTA, it's by default, it's a big bore device. It's not just a small closure device, so we had to take that in mind. You had to know well the device is based on a collagen plug that seals the artery or the arteriotomy like a sandwich pretty much. And why it's important to know big bore access and the MANTA, because as we know, the potential bleeding when we do big bore access, either TAVRs, either mechanical support, it really affects all corners in the health system, increased mortality, length of stay, and health care cost. And this is all over all the procedures, all the spectrums, including TAVRs, EVER, and mechanical support. As I mentioned before, we have two options for MANTA. We have the 14 French and the 18 French MANTA, and of course you're going to use it depending on which device you're using for big bore access. Is the one we're going to pick. And this is applicable for TAVRs, endovascular procedures like EVERs and mechanical support devices. The indications, I would say, is for any big bore access between 10 and 20 French or outer diameter between 12 and 25. And there's not really a true contraindication for this. For the MANTA, you could use it in any big bore access if you stay within those margins. It's important, again, as I mentioned, to know well the MANTA, not just going in there and deploy. You need to know the components. There's a depth locator that we're going to show a case later how to do it, a MANTA introducer, a MANTA sheath, and the MANTA closure device itself with different components, including the guide wire lumen, the bypass, the delivery tube, and the deployment lever. And the hemostasis, as I mentioned before, you achieve it by putting together the plug and the collagen, and you seal the artery like a sandwich. Why I think MANTA is an ideal procedure for big bore access, because it's easy to deploy. You get pretty fast hemostasis with one device, and you have pretty reliable closure, as we're going to hear next. I'm going to skip this video about from Telfax how to do a MANTA. We'll have a live case that we did, and Dr. Almanfi will show some of these parts too. So that's it. Now I have the pleasure to have with us Dr. Almanfi. He's going to be talking now the next talk.
Well, thank you, Pedro, for the introduction, and thanks for Telflex for having this symposium. Also, thanks for TVT for bringing us back after the last couple of years of COVID, so we're happy to be here in person. So my talk today about large bore access and closure. One size does not fit all. Those are my disclosures. So healthy access habits lead to excellent outcomes, and planning is always the key. So don't compromise on access planning and follow the best practices. I've been a fellow at Texas Heart during my training, and I'm happy to have one of my mentors here in the audience. We were taught that access is everything. You have good access, you have good outcomes. Even if the outcomes for the primary case was not what you wanted, you don't want to add more complication by having access issues. So those are the steps for having key healthy access. Number one, use ultrasound guidance whenever you can, and try to be 100% user in the lab to obtain access. We always use micropuncture technique, and that allows us not to commit to a large bore access unless we know the access is actually in a good spot. pre-angiogram using the 4 French micropuncture, a small sheath, to make sure you stick the artery in a healthy spot, so you can be able to upgrade your sheath and then finish the case. Never rely on skin markings or palpations alone, because those skin markings can move, especially in obese patients. They can change, so you have to have a very good anatomical and very good imaging markers before you commit to the access. Always do a final angiogram at the end of the case after you close to confirm full hemostasis, because that's the key. Sometimes we get comfortable with the access and send patient to the PACU or to the ICU and then get called later because the access was not perfect. So always 100% of the time try to obtain a final angiogram after you close, no matter what device are you using. So those steps I usually do in every case, whether I'm doing large bore access or even a small bore access, a PCI or a TAVR, it doesn't matter. So respect femoral access basics. So people sometimes see the crease, and the crease can move up or down. So it's better to rely on more better marking, with fluoroscopy and ultrasound and angiogram. As you can see in this case, with morbid obesity, you have a depth of the artery that's 11.6 centimeter. That's a very, very deep artery. It's not only going to be hard to obtain access, but also hard to close this access. Same thing here, and as we know, we have a very huge morbidity factors, especially in some regions of the country, in Midwest and South. So we have to respect those imaging steps rather than just go with the crease or go with the skin. I have this airplane model, which I like to analogy to use when I'm talking to physicians about access, and it resonates well with me. Doing any case in the cath lab has 3 stages mostly. Number 1 is access. Number 2 is performing the actual case, no matter what was it. Number 3 is closure. And when you fly a plane, you have 3 steps. You have basic 3 steps to simplify it: your takeoff, your flight, and your landing. So access, in my opinion, is the takeoff. If the access was poor, the takeoff is poor. The whole flight will be bad. Performing the TAVR or the EVAR or you name it, Impella is your flights. And then closing the groin is your landing. So any of those steps that doesn't go well, you're going to have a crash. So no one wants to have a crash, right? That model resonates with me and makes me divide the case into major basic steps and not to miss in any of those steps. Of course, I'm going to focus later on the last step, which is the closure. We're going to talk about MANTA later on, but having a good entry and good access will facilitate your closure at the end. As you know, transfemoral access has a lot of complications, potential complications. Many of them, as you know, hematoma, pseudoaneurysm, you name it, vascular vessel laceration, avulsion, retroperitoneal bleeding, fistula, infection. All these can be avoided, of course. All these are avoidable. And most of the causes for these complications are, related to patient anatomy, but also related to operator error. So that's one in top in red. If the operator is not following the basic best practice steps and planning the case and obtaining good access to begin with, then a complication will happen. You can see some of the case examples here where the anatomy is really horrible to begin with, and those can tell you have to plan the case differently. If you have a very severe tortuosity, like the case on the right side here, or you have severe calcification with stenosis, so you have to be ahead of time aware of the anatomy if you obtain good imaging, and you always respect the calcium, because calcium is the enemy of any interventional procedure. Too much calcium means you're going to have too much complication, too much work to do to be safe in such case. As you can see here in the bottom left, there's a circumferential calcification. This vessel will not work with any device. It's all 360-degree calcification. Here are some steps like obtaining vascular access using ultrasound needle. You can actually see the needle by fluoroscopy and see the needle by ultrasound. This is a healthy access micropuncture needle, micropuncture wire, Very, very slick here. You always watch the angle when you obtain the access. The needle entry is in the mid-femoral head here, and you have your wire. You can see a transition between the wire and the needle. They're actually going in a straight angle. There is no angle between the wire and the needle. If you see an angle at this stage, you know that you stuck the artery from the side. Side stick is poor, so you have to take the needle out, stick again, before you commit to even any 3 or 4 French sheath. And take a small angiogram from this 3 or 4 French catheter. Use the subtraction. Make sure you are sticking in a healthy spot. And if that's the case, then you pursue your case and closure. This is here an example of a poor access where you actually stick the artery in a bifurcation where you're going to have trouble at the end. Again here, try to not stick the profunda. Sometimes we go and stick the SFA if the SFA is too large and the bifurcation is high, but we do this in exceptional cases. But always aim for the femoral head. You have to use a safe margin between the top. There is a distance between the bifurcation and the inferior epigastric branch. That distance should be your healthy spot where you can be in the middle as much as you can to have a healthy access and healthy closure. And if that's the case, you're going to see a major hematoma at the end. You see this 8.6 big pseudoaneurysm because the stick was low. As you can see, there's multiple devices in the market. Historically, there was a ProStar. I was trained on ProStar at Texas Heart at some point. This device now is falling out of favor because it's complicated. It's 22 steps, so the learning curve is huge. And I'm glad now I'm not using it anymore. So we try to use a device that's very intuitive, very easy steps for the operator to learn and to be reproducible. So ProGlide is very commonly used, probably the most commonly used device. I think it's off-label for a large bore access. You have to use 2 to close a TAVR or close a impella sheath. But it's very easy, 6 steps. It has its own on-label and off-label indication, and we're going to talk about what are the best practices for MANTA, which is we're going to talk about it in depth today. There's two types, 14 French and 18 French system. There are other devices, ProSeal and InSeal. But currently in the United States, the only device approved for large bore access is the MANTA. Large bore access, there's a huge need. As you know, TAVR practice is growing every day. And we cannot do TAVR from 6 French. We still have to use a large bore access for TAVR. Same thing for EVAR to exclude aortic aneurysm, TVAR, mechanical support for impella. So there is a huge need in the lab for large bore access best practices. And all they use, femoral access. We still do some cases from alternative access, but we're going to focus mostly today on femoral access because that's the most commonly used. And data have shown that transfemoral TAVR beats surgery just because it's transfemoral. Closure of these sites need to be done, in a careful way using whatever device you're comfortable with, but follow the best techniques. Despite the widespread use of those methods, still major vascular complications still happen. This is MANTA, as you know. It's the first commercially available device that closed the large bore access, 18 French and 14 French. And it can be used for any of the procedure we mentioned, TAVR, EVAR, ventricular assist device support, ECMO, you name it. The first trial was done in 2018 and 19. It's called Safe MANTA trial. And this was a pivotal study that led to the FDA approval. Dr. Krager is my mentor. He's one of the co-PIs. This study was conducted in multiple centers, about 20 sites. They use MANTA for all these patients, about 263 patients in North America and US and Canada. They use certain criteria, of course. They use systematic angiogram for each post-closure. It was used mostly for TAVR, but also for TVAR. And that study showed many lessons we learned initially. For example, it showed the median closure time is about 24 seconds, which is now even has gone better with the widespread use of MANTA. Also, it showed that the complication rate was low, 4.2. But those operators, as you know, were selected operators. They have good experience with MANTA. They use good selection. That's why the outcome was really good. And based on that study, FDA approved MANTA to be commercially available in the United States in 2019. Those are the data from the SAFE MANTA trial. I went ahead and looked at literature and look at some of the studies that was done. Many of them are retrospective studies. None of them is randomized. And as you can see, there's a data from widespread data. It's variable because some of these trials were done, or studies were done in people who were selected for MANTA closure. Some were actually all comers. So when you use one device, let's say for all comers, sometimes you will have extra complications. So the key question is being selective and being aware that one size does not fit all. So I'm a big proponent of case selection. So I'm not going to say every case should go MANTA or every case should go ProClose or ProStar, but we have to be aware what the anatomy looks like and what the patient need to have a safe closure. And I will go over some of the criteria that so what do I do in my day-to-day practice? Not one size fits all. I use 14 French MANTA if the femoral artery is less than 5 millimeter. So we have a CAT scan. We have to make sure the artery is sized appropriately with a good quality CAT scan. If the artery is 6 millimeter and above, then I can use 18 French. So that's one selection criteria. No significant posterior calcium, because that might make the foot plates stuck at the calcium and cause complications. Verify the depth very well. You have to know how deep is the artery. The depth of the artery is the most common problem that happen with all the complications we see in the lab. If the artery is too deep or too shallow, you have to know ahead of time. By doing the depth locators, even do it more than once to make sure we are doing it right. Look at the CAT scan, and of course you have to use an angle. Look at the ultrasound. All these factors can give you an idea how deep is your artery. So use more than one way to confirm your depth. Follow best practices to obtain access and apply appropriate techniques for MANTA device deployment. Those two different steps. So obtain access in very good way, as we explained earlier. Spend time on access, and also know the device and how to do it technique-wise, because also not understanding the device itself might lead to complication. Make sure blood pressure is well controlled. Pay attention to ACT. The MANTA device is not a large angioceal. I meant to make this in red, but it came as wide. If you ask any of the interventional cardiologists nowadays across the country who doesn't use MANTA, they will tell you, oh, it's a big angioceal. But in fact, it's not large angioceal, because the technique is different, the concept is different. It's just because both are collagen, it doesn't mean they are the same. And we will show that later. So I'm going to show you this video quickly here. Hopefully the sound is not too loud.
Enter a new era in large bore closure with the MANTA vascular closure device, a device designed specifically for closure of large bore femoral arterial access sites, following the use of devices or sheaths ranging from 12 to 25 French outer diameter. Before the large bore procedure, determine the depth of the access site using the depth locator. This is fully inserted over the 0.35-inch guide wire until blood flow is detected at the outlet. Retract the depth locator until flow stops, and note the position number at skin level, indicating the access site depth. Add 1 centimeter to this depth to determine deployment depth for later device positioning. After the large bore procedure is completed, closure begins by exchanging the procedural sheath for the MANTA sheath over the guide wire. Fully insert the MANTA sheath into the vessel and remove the introducer. Advance the MANTA closure device over the guide wire. And after advancing the bypass tube, fully insert the device into the sheath until a click is heard. Slowly retract the device and sheath at a 45-degree angle, observing the markings on the sheath until positioned at the previously determined deployment depth. Maintaining the device at 45 degrees, rotate the deployment lever to release the anchor and begin to withdraw the MANTA device from the artery. Steadily withdraw the device from the artery until tension is felt and the handle indicator window shows yellow-green. Maintaining this yellow-green tension, gently advance the lock advancement tube to position the radiopaque lock. While stabilizing the vessel with the lock advancement tube, retract the device slightly until a click is heard. The access site is now sealed. The lock advancement tube may be retracted to assess hemostasis. Once hemostasis has been confirmed, remove the guide wire. The suture should be cut below skin level. The MANTA anchor is low profile, non-thrombogenic, and resorbable. The radiopaque lock remains and is angiographically visible to guide future access 2.5 centimeters above or below the previous site. The MANTA device is available in two sizes, 14 French and 18 French. The 14 French MANTA device is indicated for closure of femoral arterial access sites following the use of 10 to 14 French devices or sheaths with a maximum outer diameter of 18 French. The 18 French MANTA device is indicated for closure of femoral arterial access sites following the use of 15 to 20 French devices or sheaths with a maximum outer diameter of 25 French. With the MANTA vascular closure device, a new era of simplicity and confidence in closure is here.
So as we could see, the steps are very easy, very intuitive, and I will just conclude my talk today by saying MANTA is very intuitive, very attractive, dedicated large pore closure device. There is a steep learning curve, and we're going to debate today a discussion about different practices and what the learning curve looks like, and fast adoption in clinical practice mimics trial outcome data. Thank you so much.
All right. Thanks so much, Abdel. That was a great talk about access and patient selection and how to avoid complications. Now I have the pleasure for Dr. Michael Stoner. He's going to give us the second talk. He's going to be managing large bore arterial access lessons learned.
All right, thank you for the introduction in the stalwart crowd here early in the morning. And I'm a vascular surgeon, so I may be the only vascular surgeon at the meeting. I'm not sure. I'm a little nervous though. And but I'm happy to speak to you about my femoral access technique and thoughts about strategy for femoral access. I perform large bore femoral access extensively for a EVAR, TVAR practice that I have, a lot of axillary artery PERC access, and then we have a large complex thoracoabdominal aortic aneurysm PERC practice as well. So we're well versed in it. And then with that said, we fix a lot of complications from various services, trauma service, MOAB, balloons, all those sort of things. And we realize a lot about the failure modes of large bore access. And I think I'm going to dovetail a lot on what's been said because it's the alpha and the omega of the case, and the access is the entire case. And you know, percutaneous access is obviously the dominant mode. I'm a vascular surgeon, and I'd say 80% of my life is percutaneous at this juncture. A lot of it 24 French sheath percutaneous, but it's percutaneous. Patients prefer it. The studies from our institution have shown a lower narcotic use of percutaneous use, revascularization for things like critical limb ischemia, et cetera. Essentially no infections happen. We did a large-scale VQI trial that showed that if you take patients with metabolic syndrome and you compare the open groin access EVARs to those with PERC access, you essentially have no infections in the PERC access arm and actually a relatively high femoral infection rate in EVARs in patients with metabolic syndrome. But there's a lot of ways to screw it up, a lot of ways to foil this access. ultrasound all large sheath access, and in fact, ultrasound all sheath access. I think ultrasound is mandatory for every arterial access at every point in the body, be it the radial artery, be it the brachial artery, be it the femoral artery. Any artery you want to access, ultrasound is readily available, high quality, and should be used for every single arterial access. And the outcomes, there's a lot in the literature, and I'll show some other studies, but this is a study that we published in the Annals of Vascular Surgery about 3 years ago that looked at the VQI database and large sheath access complications and small sheath access inside the PVI module of VQI. So these are peripheral vascular interventions, a lot of cases, about 40,000 cases, looked at it around the US. VQI won't give us center data, so we split it up into regions. So you can see there's heterogeneous uptake, but the important part of the study is shown on the next slide, which is complications. So this is just justification for using ultrasound access. Composite complications, which are hematoma, false aneurysm, thrombosis, embolization, dissection, and perforation. You can see the individual p-values in here. They're all safer at the sites that use more ultrasound access. So ultrasound access is safer, and there's zero question about it. So what do I think about when I'm going to perform, be it small sheath or large sheath access, and how do I talk to my trainees about it? And break it into 3 steps. It's searching for the target, which is pretty useless. We've already heard about that. That's palpation. That's really just the presence of the pulse. Confirming the target via ultrasound and hitting the target correctly. So again, why do we do ultrasound? There's some real-world data in that, and the FACC trial shows that as well. I'll skip through these slides pretty quickly. Bottom line, using ultrasound versus fluoroscopy, ultrasound is superior at number of attempts, risk of venipuncture, first pass success rate, and time to sheath insertion. So it's better, and it's also better for complications as well. So the palpation method really doesn't work, and so we're all taught this. I was certainly taught this way. Feel for a pulse, put an 18-gauge needle and put a wire in. That's how I was trained in my fellowship. And then when there wasn't a pulse, take a micropuncture and do the Singer sewing machine and search like crazy for blood. And then if you can't find it, find another access site. And that's essentially how a vascular surgeon was trained in 1998 or so on how to do this. But it's really rarely the point of maximal pulse impulse is the target that you want to hit. And I'll show some animal studies that demonstrate that. So the role is we have to confirm the target. It's the artery, not the vein, not a lymph node, not anything else, and that's by ultrasound imaging. So we don't want collateral damage, and there are a lot of structures that live in that area, and it's a relatively high-rent district, right? Femoral, I've seen the femoral nerve injured, I've seen the vein injury. Remember, there's the coronavenous vein that passes from the profunda femoris around to the superficial femoral vein, right around that bifurcation. A whole bunch of structures where AV fistulas can form, access complications can form. So it's something I consider a highly packed, high-rent district in a very small area in the body, similar to the carotid artery. Our target is the common femoral artery, and the operator must see the needle directly in the middle of the common femoral artery of that imaging plane, or the operator is making an error. It's that plain and simple. If you can't see the needle tip exactly where your imaging plane is, you've accessed that artery incorrectly. It's not the deformation of the artery, it's the placement of the needle tip in the dead middle of the femoral artery. You see lymph nodes all the time, other structures. This is hard on obese patients, so you should be comfortable with using lower frequency probes that penetrate deeper and to see what's going on, but you need to be well versed in ultrasound to do large sheath access and really to do any access. Calcification is important. Ultrasound is excellent at looking at calcification, and will often sometimes call off that access site, switching maybe your large bore access to the contralateral groin, or even a strategy for open femoral exposure versus percutaneous exposure. But it's important to do both axial and longitudinal imaging, because you can often salvage calcification with longitudinal imaging and deciding where to access exactly. So, hitting the target, right? So there's a myth about the mental picture that we all have, and it's, obviously we teach people, if you come into an emergent situation, you don't have ultrasound, access the dead middle between the groin crease and the inguinal ligament, which you can feel from the ASIS and the pubic symphysis. You can feel those structures, you can access the dead middle. You'll be right a lot of the times. You're going to be wrong sometimes as well, but this mental picture that we have here is fictional. And if you look at it, here's some angiographic examples, and I'll show some animal autopsy and human autopsy studies in just a minute as well, that there is risks of retroperitoneal border being lower. And this is an example where you can see the loop of the epigastric artery coming off really in the middle of the femoral head. But if you did fluoroscopic guidance, you would access the external iliac artery and have a risk of RP hematoma. And remember, high access kills people, low access gets an ischemic leg. You take low access over high access, but they're both bad. Here's a high femoral bifurcation. This is a case where if it wasn't a large sheath access case, access to the superficial femoral artery or an alternate access site would be reasonable. Remember that when there's a high bifurcation on one side, there's almost always a high bifurcation on the other side. And if you look at it, this is a study. Then the histogram shows the access, shows the femoral head. This is an autopsy study, and where the reflection of the retroperitoneum is. And that histogram demonstrates it in a series of patients undergoing postmortem, and you can see that it's variable with respect to the femoral head. So basically disproves this idea that fluoroscopy is an adequate way, pulse exam of fluoroscopy is an adequate way. And a lot of these patients, if you access what would be considered the F1 portion, the top third of the common femoral artery, you would be accessing through and into the retroperitoneum. So it's very, very important to reboot your brain when you're thinking about femoral access. And the main goal is not just the common femoral artery, but we really want to hit about a centimeter above the femoral bifurcation. That's the ideal place to hit, ideal place to hold pressure if there's a failure mode, and from a surgeon's perspective, the ideal place to cut down and salvage the problem if it can't be salvaged from an endovascular standpoint. And then lastly, this was mentioned as well, we live in a more anticoagulated world, and we have a higher risk of our patients. And I'm a vascular surgeon, so I operate on DAPT all the time. The neurosurgeons who have a prominent stroke and intracranial practice, all of their patients are on DAPT, and they're tested to be responders, and they're on Ticagrelor or DAPT and aspirin as well. So they're on a very anticoagulated patient cohort that we're dealing with. So the only way around that is safety. That's perfect access. So I'm going to go over some complications for the last 3 minutes, but in summary, reliable femoral access is absolutely mandatory for all endovascular cases. That can be a 5 French diagnostic for bypass planning. The tactile and fluoro feedback is completely outdated, should not be taught, and is not taught to my trainees. You have to master ultrasound learning curve. And the way to do that, if you're going to get into large shore access, now we're in a structural heart symposium and everyone here does large sheath access, but what I talk to my trainees about is we do this on the 5 French sheath case before I let them get access on the E-bar and the T-bar with the 18 French sheath, because we're going to master perfect 5 French access as well. So a couple other thoughts I have about access complications I see. The iliacs, again, if the access is the alpha omega, the iliacs are the other alpha and the omega. You have to be worried about iliac access, so I know that it's not the topic of the symposium, but our job is to avoid the iliac on a stick. Less of an issue for us now with hydrophilic sheaths and just better E-bar and T-bar delivery devices than we had when I started training. But you have to be cognizant of how you're going to manage the tight iliac of the sheath going in. So it's important that the operator that places the large sheath also removes the large sheath over a stiff wire with a dilator in place, because that operator has the tactile feedback already in their mind, the proprioception of where the tight points are of the access. You have to be ready to repair problems if problems arise. What I found about it that's really important about iliac complications when they happen, and we don't see it very often anymore, there's no real arbitrary cutoff for vessel size and complications, and that's because patients have different vessel compliances. Heavily calcified vessels that are of large enough diameters can be cracked and paved. I'm more wary of the small iliac vessel without calcium. It will not dilate. The key danger zone of iliac injuries is the iliac and aortic bifurcations, because that's where the media of the vessel, the smooth muscle cell layers, split, and those are the natural tear points. So when they happen, tears in blood vessels happen at bifurcations. Always consider, for us, preemptive aortic conduit can be endo or open, but consider preemptive conduit if femoral access is required. The other part I think it's important is that if you're a large sheath access surgeon is that you're very fast on the preoperative case planning in 3D imaging. Do not rely on a radiologist's assessment for 3D imaging. Anyone who's going to place central aortic devices should be confident in constructing their own 3D model in various workstations. The platforms are incredibly user-friendly to use now. All institutions who have CAT scanners have these platforms available. You should reconstruct your own iliac vasculature, create the center line, and look at it. It's very easy to do, much easier than it was with the software products that were on dedicated workstations 15 years ago. We use Terra Recon and Philips and Telespace at our site. Vital Images as well is very good. But you need to be comfortable at assessing your own access, not just looking at axial imaging, because axial imaging is wrong on tortuous vessels. Paving and cracking is reasonable. I don't do this a lot, but it is something we do from time to time. Now we use shockwave a lot of times for this as well. But remember, it doesn't solve basic size mismatch. A small vessel without calcium is more dangerous than a calcified vessel, and you can't fix the physics of something too small to take a large sheath. Got to be ready for balloon occlusions if problems happen. We usually in the OR use a coda, or we like a Q50 balloon because it goes over a short wire. The amplastic sizing balloon is a good thing to have as well. Alternate access sites are very important. But femoral access is something that I'm very adamant about, very diligent about. But you have to be very careful. You need to have absolutely perfect access. The needle, if you can get that needle in perfectly in a non-diseased section of the artery with a centimeter above and below it that's adequate for a closure device, you're going to be okay all the time. But you got to know how to do the ultrasound. You got to watch that wire tip enter the dead middle of the lumen of that artery, or you're not doing it right. And that's something that my trainees have heard me beat into them multiple times. And I'm sure the esteemed faculty would say as well. It's the absolute most important thing. But this is device closure, device agnostic. It's all cases are predicated on perfect access. Thank you.
Okay, so this is something I think we all highlight. Big bore access, don't expect success, prepare for it. That's what we tell all our fellows. Don't go inside if you don't know how to come out. And most of the TAVR planning is also mechanical support or procedures planning, and then there's 5% skill sets that you have to develop. And as we know, to do these procedures, to do an EVER, to do a TAVR, to put an impella, the easiest portion is to do the actual procedure, but the most difficult is to deliver the device. So you have to be prepared, you have to assess your anatomy, and most vascular complications happen because you were not ready or you did it inappropriately. And this is an essential kit, I would say, for anyone that does endovascular big bore access. You have to use everything that you have in mind: CT, ultrasound, IVUS. I use a lot of IVUS sometimes. I think CT sometimes undersized vessels, or they don't tell you everything, so I IVUS them just to get a better idea. Use all the equipment that you have for bailout. Don't go into a case if you don't have the bailout in your room, otherwise it's going to be a catastrophe. It could end up in surgery, and if the surgeons are not available immediately, the patient even can die on the table. And then for closure device, be ready, know how to manage every different type of device, including for suture base, collagen, and then even manual. I do think manual pressure now they don't teach it well. Make sure you know how to do manual, and of course endovascular bailout. And these are usually the expectations, at least in the Midwest. The ideal anatomy, I would say, is only in a third of the patients. Most of the times we get that the reality on the right side, and this is when things get more complicated, because now what we thought it was going to be a straightforward access is not. And for that reason, there's a lot of discrepancies even within our own systems about how to get access. So when we teach the PUI 8 fellows, the last fellows, the structurals, how to get access, I know they're interventional. I call them the Villablanca's rule, because I just cited this Jack paper where they tell you how to get access, and if you look at the paper, I would say that's the wrong access, and it's on the paper how to get access. In my opinion, it's not just ultrasound guided, it's fluoroscopy and ultrasound guided. You have to locate the common femoral before you do any ultrasound, because if you're getting above the bifurcation but you're too high or too low, you're going to get access, and you should be on a compressible side. Always, as Dr. Stoner said, always do it at least 1 centimeter, because you have to start thinking about the bailout. You don't want to stick at the bifurcation, and then if you're compromised, you're going to be compromising two vessels, the profunda and the SFA. So it should be always on the compressible side with some distance. And remember, the books are not there. So when they tell me, oh, it's on the books, the SFA has no branches. There's only two major vessels. Sorry, the common femoral has no branches, and you only have the SFA and the profunda. I would say that's only 1/3, 1/4 of the patients. There are several branches on the common femoral. There are sometimes multiple profundas, so don't go by the book. Use the functionality of the vessel. Sometimes you have a high bifurcation, but you have a big SFA that works functionally as a common femoral, and you have to go from there. And then don't use shortcuts. If you're doing big bore access and you have a calcified vessel or obese patient, don't just push blind. Do escalated upsizing from the micropuncture to your, I use a lot the radial sheath in the groin because it has a slender tapering more than most of the femoral sheath. And then I go to the femoral sheath over stiff wires. And then this is my own algorithm, how to select closure devices for TAVRs. I would say in our institution, when someone is obese or with a hostile groin, as I call it, we don't have no-brainers. We go with the MANTA. The main reason is good luck sending the pushers of the suture base down. Even if you prep the track with Kelly, sometimes you can't reach the arteriotomy, and you're not going to be closing that big bore. If you have a healthy vessel, it should be operator comfort. In my opinion, when you have circumferential calcium, your suture base will not go through it, or if you go, they're not going to seal. So my preference is MANTA. Always be ready if you get caught on the calcium. There's some techniques that we could talk about later how to prevent this. If you have anterior calcium, I would say just go with the MANTA because you usually get caught on the posterior. And if you have posterior calcium, I would suggest suture-mediated devices, but if you're an advanced operator with MANTA, you could use it as well. And the important thing that when we do TAVRs, especially in this structural symposium, is like you want to keep the minimalistic approach in TAVRs. I do biradial, one for the embolic protection, and secondary access for the MANTA from the left radial, left distal radial, and you keep the minimalistic approach. So you get worried one access and not two, and that's how we do, I would say, 95% of our cases, and patients go home next day, no anesthesia, no ICU, etc. And, but the most important thing I would say from this message, be ready. Have all the equipment ready before you enter the room. Make sure you have the cover stands if you need them. Make sure you have the balloons that you need for that size of vessel. Make sure you have the ultrasound and everything you think you might need to bail out. Based on my experience, this and the recommendations of usage, if you're using an Edwards valve, I always use 18 French MANTA as long as the vessel size is adequate, as Abdel mentioned. When I use Medtronics, I like to use a sheath when I introduce the Medtronic valve because I do think when every exchanges of the valve, when you put a sheath, 14 French sheath, and then you put the valve, and then you take it out, every time you exchange big bore access devices, the arteriotomy gets damaged. So I tend to use a sheath to deliver the Medtronic valve. But if you don't want to use that, you can also use the 14 French MANTA and be ready. If for one reason you're doing the MANTA and you pull out unintentionally when you're deploying it, don't freak out. You can always go with the bigger device and go back to an 18 if you decided to use a 14 French MANTA. And the steps and I'm going to show a video. I'm going to go quickly here, but I would say when I'm getting access, I know several people use cardiac mode, not the non-digital subtraction. I actually use a lot of digital subtraction because it gives you much more details of the vessels from the common femoral or extra profundus, etc. And you get a better sense when you're closing if you injure any small branches than usual conventional cardiac mode fluoroscopy. I'm going to skip this because I'm going to show you. So this is our standard case at Henry Ford, and I'm just going to start. So this is, as you can see, biradial. This is our fellow. He's marking the common femoral already on fluoro just to have an idea before he even got the ultrasound in. Then he locates the common femoral. You can see it's very pulsatile. He sees the depth. And then he's getting, and it's very important when you get access with the ultrasound is anterior. You're not getting it on the side here on this angle because I do believe if you go from the side, you're gonna affect the sealing of any suture or any plug devices. It should be anterior when you're doing this. Otherwise, you're gonna be paying the consequences after. Once you do that, I think here you get access with the micropuncture. Then always follow the wire on fluoro. The main reason is not frequently, but I've seen this wire instead of going where the vessel is here on the right, going into the pelvic area, and then you get bleeding. Where's the patient bleeding? You take pictures of the common femoral. There's no bleeding, and everything is happening on the pelvis. And the problem with those bleedings are delay bleedings. You don't see them immediately from the big bore access, and there was no problem about your location or the technique. It was you were not following the wire. So I think follow each step when you're doing this. Okay, and that's, let me just go for the next one. Okay, the next, when you get access, and again, consider DSA. Why? Because again, you see much more vessels, all these small vessels that we're seeing now. Sometimes when you do conventional fluoroscopy, you don't see it, and you could, and those will be important when you do the final picture. Here, once we do that, and here this patient wasn't obese. I just did it for the purpose of the talk. But if you have a hostile growing obese patient or calcify, I usually send back the micropuncture wire over the micropuncture sheath, and once that's done, I send the radial sheath dilator to make the transition of the vessel much smoother when I'm going with the femoral sheath. And I think this really facilitates the delivery of the A-French sheath from the MANTA. And before I send the A-French sheath from the MANTA, I use the A-French femoral sheath that I'm going to be using to exchange the wires later to kind of create the track for the MANTA measurement. The next step here, when you're doing the MANTA device, don't have any tension on the wire. I know there's a tendency when we're sending things into the body, someone gives you rail. In this case, I would say just tell your tech or your partner, your interventional, your surgeon or your vascular surgeon, just to leave the wire there and do your assessment here of the measurement of the MANTA. If you have an obese patient or you have a lot of tension of the skin, just push it down. Just make sure whoever is doing the first measurement either do the closure, because if you do the measurement and someone else comes and do it, there could be some variation if you have some blood extravasation between exchanges of big bore axis, and you could have a wrong measurement when you're closing. And after you do that, you remove the MANTA depth locator, and then you go for the next step. You ask your tech or yourself to prepare the MANTA. Pretty much, it's pretty easy to prep. You have to flash your dilator, and after you flash your dilator, you put it into the MANTA sheet here, and then you lock it in, and then you're ready to go. Okay? So let's say everything went well, you did your TAVR, and this is something that we'll learn as we adopt MANTA in our institution. We like to send everything under the stiff wire. Why? This is a big bore access device. We saw at the beginning, if we used a soft J wire, there was a lot of wire buckling. Sometimes in obese patients, we didn't have the support. So I do think it's very important to use the stiff delivery wire to use it. The other thing, if you're using an E-sheath, I would say sometimes when the E-sheath comes with, in a D shape or like L shape, to avoid arteriotomy damage, I like to send the dilator of the E-sheath put it back again to avoid arteriotomy damage when I'm taking this sheath out. So that's something that we do in our practice. You don't have to do it, but I strongly recommend to use the dilator before you remove the sheath. Once you do that, again, don't do it by yourself. Ask someone to hold pressure of the big bore access. You remove the TAVR sheath, and then you go with your MANTA dilator sheath in over the stiff wire. Once you're there, and I think this is key, remember, MANTA is a big bore access, so do it under fluoro. We like to see that there's no wire buckling, etc. So we send it under fluoro, and then the next step is what we like to do once your MANTA is in, we switch the stiff wire for the soft J wire that you did the initial measurement when you were getting access. So we switch that. So we take the stiff wire and we put a soft J wire to do to deliver the plug. You can see it here. Someone is loading your plug. When someone is loading the plug, make sure to tell them not to have any tension on the back of the wire. Once you take over the plug, the first operator, there's no rail that needs to be made from the back. You just push it. Make sure you push it very proximally. You don't push it distally, otherwise you can bend the MANTA. And when you go in, make sure you do a double click, and that should be. Once you're ready, I recommend the fellows or any operator when you're starting MANTA to do a tilting maneuver. Don't just push it back. The main reason, especially in skin patients, you might just jump outside of the vessel if you do it too quick without like a tilting maneuver. And this tilting maneuver allows you to get better control to reach your depth. Once you reach your depth, especially in obese patients, I usually like to correlate on fluoro that I'm at the level of my entry point when I got access, because again, when there's exchanges of big bore access, you can have hematomas that were unintentionally caused, and your depth might change. So I strongly recommend to get fluoro check when you do it. After you do that, you raise the lever. And again, this is very important. Just go slow. I always say, if you see blood coming, that's actually normal. The heart is beating, there's flow through your leg. Don't rush. Most of the errors with MANTA happens when they see this blood coming out, and they go fast, and then they ended up either going through the vessel, rupturing the vessel. So don't worry about that blush. It's all normal. You see, and then you just finish here. Sometimes when there's skin patients and you see like a small blood accumulating, just squeeze it quickly. It's just the blood because of their skin. You see it more than in obese patients. And then, and then once you're done with this part, so once you're done with this part, I like to correlate on fluoro, especially in obese patients. It might happen that your plug is not all the way down, so you might see your radiopaque marker lower here. That means you didn't reach the arteriotomy. Once you check that, you can remove the J wire, and then once you remove the J wire from the MANTA, I guess you can see that it looks great. I've heard some people, when they do big bore access, even if it looks good outside, make sure it looks good inside. So I never go outside the room without taking a picture. And you can see that there's no bleeding here, and the MANTA is located where it should be. And then these are some troubleshooting maneuvers. Like sometimes when you see bleeding, what could happen is you didn't do a good deployment, like the 45-degree angle of 60, you didn't do it well. So it could be that your foot plate is stuck on the posterior wall. What you could do, just tilt the wire, pull it back, and you will just, pull the plug into the access point, and you will seal it. And the other thing that can happen too is that your plug went all the way down on top of the vessel. So what you can do is just hold the MANTA back the same way you were delivering and push the blue line here. And you could see it on fluoro. In this case, it was well delivered, but sometimes when your radiopaque marker is below of your access point, you can push it and make sure that your plug will be reaching the access point. And then you just got the suture and you're all done. Meaning I'm just gonna skip this. These are pretty much some of the recommendations. I say just keep the blood pressure below 150, reverse the program if you can. If you're not well versed in endovascular, have a balloon ready, have your equipment. This is our experience with the first year, like 4 years ago with MANTA, 3 years ago. It was pretty good. We have a success rate without doing anything of 93%, and there was some oozing with some of the MANTA, and we just corrected with ballooning, but it worked great. It was presented at ACC. There's always, we're going to debate a lot quickly, but there's a learning curve. Sure, not everyone has the same skills. Some people might take longer than others to dominate the MANTA, but I would say as long as you understand how it works, it's a pretty easy device to use. And the most important from these talks from everyone is just to assess your anatomy, know your equipment, use ultrasound, and be ready to treat any complications. It will happen with any device. It's going to happen in the future. If it doesn't happen, that means you're not doing many cases, or you're the most skilled guy in the world. And that should be. And I would say we'll have some time for questions. And I'm going to ask my co-moderators. I think one of the things we can take conclusion is when we're doing big bore access, I think we all agree that it's essential. I think if you don't get a good access, that's when you're going to be paying the consequences. So I guess if you guys want to comment, I think it's mandatory nowadays for all this big bore access to do it with ultrasound fluoro guided, and have the equipment ready in case things go south. I leave the open questions for you guys.
Yeah, I think that's exactly right. And I think the step I do is same as you, is I shoot through the micropuncture at the axis, even for like a 5 French sheath, because there's no harm at that juncture. And I think that's the key thing. So I put the little 4 French micro in and verify the access. But the ultrasound's usually, if you do it right, you're right. But I think that's an excellent next step. Yeah.
I totally agree. The access is everything, as you mentioned, and it's important not to push so hard if the access is not healthy, to commit to a large bore procedure access and then do the case, and then what happened after that is a disaster. So careful planning and selection is the key. And also looking for alternative access. If the femoral access is very small and the iliac is small and the case cannot be done femoral, then let it be. Just go alternative access and look for other safer options. Getting surgery cut down also an option. You know, I know we try to avoid that as much as we can, but in cases sometimes the femoral artery is just hard to access percutaneously and close safely without, so do a cut down if there is need to be. I think pushing the limit on such devices like MANTA on unhealthy access habits on a healthy artery is that what causes problems, especially in early learners.
Do you have any advice for the early adopters now of MANTA? Should they start with more simple cases and then go for more complex? Any advice for the people that are?
Absolutely. For new users, at least for the first 20 cases, you know, try to go with the instruction for use, go for the IFU and not to, you know, go into those complicated, you know, cases. And there's a lot of patients, luckily, who have healthy femoral artery and iliac artery. So if you're a new learner, just go with the simple cases like anything else, like TAVRs. We advise people when learning TAVRs to start with the first simple cases, you know, straightforward transfemoral. Same thing apply for closure. I want to comment about the TAVR since you mentioned one point about multiple exchanges. I agree. You know, when you do a TAVR with Edwards valve, you will have one exchange, so that makes sense because every time you push the artery with a dilator or a sheath or whatever, you are causing a trauma to the artery, right? So that will count later on when you repair it or you close it. So the minimum amount of exchanges you do is better. Was the best. For doing evolute, I'm a high evolute implanter, so what I do, I try to minimize the steps as well by using, for example, one sheath, 14 French sheath one time, and that can make the artery ready for go in line without sheath. So I put the 14 French sheath as a dilator, get it out, and then go with the evolute valve. Deploy the valve, and then once I'm done, take the catheter out, leave the wire, and put the MANTA sheath. So by doing this, you basically access the artery with two sheaths instead of multiple. I've seen many operators, they take the delivery catheter out, they put a sheath, and then they put the MANTA sheath. That's probably an extra step that can be avoided easily.
That's great. And just because of the time, Michael, any cases where you would consider either not using any suture-based or plug-based MANTA and just call you or our colleagues in our hospitals for a cut down if there's no alternative access? Meaning,
Yeah, no, I think there's nothing wrong with preemptive cut down. I think we're all in this mindset that we're going to try to do everything percutaneous, but a nice preemptive cut down solves the problem when you have the circumferential calcium or the big bulky posterior calcium all the time, because those patients often need like a femoral endarterectomy anyway. So it's preemptively is a great idea. Your point about the sheath exchange is spot on. And for some EVAR devices that we use that are not like a Gore device that runs through a single sheath, we'll trade to a larger dry seal to put like a Terumo in just to not have the sheath exchanges. You're right, it beats up the artery. You're exactly right.
Okay, well, thank everyone. Those were great talks, and happy to share any comments after the end of the session. Thanks, everyone.
Thank you.